Move on to approval of minutes from the prior meeting. I see a correction on here. The change on page 32 from should read Dr. Ushkow, not Dr. Upton. Any other corrections? Seeing none, motion to approve. Somebody? Anybody?
So moved.
Thank you. Second? Thank you, Steve. All those in favor? Opposed? Okay. Correspondence. Disciplinary actions. Gabby Day, Brooklyn, New York. Her certification is suspended for 1 year effective May 19, 2014. 30 days actual suspension, May 19 through 6/18/2014. Remaining 355 days are stayed for violations of Part 800.16 subset E. Joseph Baldwin, North Babylon, New York. Certification suspended, deemed to have been served concurrently with the responder's actual suspension by the Suffolk County REMAC. In addition, he was placed on probation for a period of 3 years, effective April 30th, 2014. Assessed a civil penalty of $2,000 for violations of Part 800.15B and 816G. All the other correspondence are up here if anybody would like to read them. Course applications, we have Hudson Valley Paramedic Original class. AFD day class starts November 12th, 2014. And Lake Placid Volunteer Ambulance night class starts August 25th, 2014. Any questions on any of that? CON committee?
The CON committee did meet this month and discuss the matter of Delmar Bethlehem EMS transfer of operating certificate. And we'll have 2 motions to bring up under new business concerning that.
Go ahead and do them now.
The committee met and discussed the application. We had 2 questions on it. So this is a motion by Rich Brandt to bring forth. It's seconded by the committee. The motion is to accept application as complete and also accept the Department of Health's finding of no apparent bar to fitness and competency of the new operators pending receipt of the wording of the new operating certificate, which strikes the words, quote, within the town of Bethlehem, unquote. Refer to Schedule F on the application. And pending receipt of the $7,500 CON deposit. Both items were satisfied, and we have documented receipt, and so bring that as a motion.
Okay. So which motion do you want to deal with first, Jim?
That one.
The transfer?
Transfer.
Okay. So an affirmative vote would be in favor of the transfer of operating authority, and no would be against it. Agreed? Jim?
I think you're just voting on the fitness and competence.
Oh, is that all we're doing?
You're
My apologies. My
accepting
apologies.
the department's finding no bar to the fitness, no apparent bar to the fitness and competency of the proposed new operating,
Okay.
I believe.
We'll start with Les Freemantle.
Yes.
Bill Price?
Yes.
Jim Regan?
Yes.
BJ Keeler?
Yes.
Aiden O'Connor?
Yes.
Jim Dorwan?
Yes.
Kathy Allen?
Yes.
Kevin Robert? I'll vote yes. Dale Lingenfelter?
Yes.
Jim Vina?
Yes.
Chris Kehoe?
Yes.
Mike Daly?
Yes.
Al Jagoda?
Yes.
Steve Kroll?
Yes.
Rich Brandt?
Yes.
Jim Stairs?
Yes.
Skip Nierny?
Yes.
Zoranda? I always goof your name up, I'm sorry.
Sorry. Yes.
Thank you. Steve Retzloff?
Yes.
Anne Marie Cross?
Yes.
$20 yeses. Unanimous vote. And the other motion was to reduce,
Our second item was, for those of you familiar with the CON process, regarding the transfer of operating certificates is a lot less involved with the process generally as other operations. So a second motion has been made by Rich Brandt, that is to decrease required deposit for transfer applications from $7,500 to $1,000. That was seconded by James Venna and approved unanimously to bring forth as a motion.
any questions from anybody? Any discussion?
Just a clarification, as the motion maker, this would apply only to transfer applications, not to new applications, nor to expansion of operating territory applications.
Thank you. Any other questions, discussions? All those in favor?
Aye.
Opposed? Okay, motion carries. Thank you, Jim. Executive Committee, everything we discussed tonight will be brought up. There is one item that needs to be brought up from last month's meeting. PJ, do you mind taking care of this?
Sure, no problem. Last month's executive committee meeting, we had a discussion revolving around Tim, based on his performance and his long-standing history with the Remsco here, the performance that has taken place and how well he's done in meeting the objectives that have been put forth before him. The executive committee at the time voted overwhelmingly that there was a discussion regarding his base salary, and that we voted overwhelmingly to raise his base salary by $5,000. In so doing, what we failed to do, obviously, was bring it to the full Remsco board. I don't know if there was a confusion over the CON vote last month or whatever, but we failed to do that, and that motion does need to come before the Remsco board as a whole for approval.
Comments, questions from anybody? Okay, seeing none. All those in favor of approving Tim? Actually, no, we need to make a motion, technically. Is that, you're making a motion? Thank you. A second, please.
Second.
Thank you, Steve. All those in favor?
Aye.
Opposed? Okay, motion carries. Thank you, PJ. We'll move on to Executive Director's report.
Hopefully everybody has a copy.
Kevin, I wanted to abstain from that vote.
Oh, my apologies, sir.
That's okay, no, it's no problem. This is not a reflection on the executive director or on the performance or on the subject, but rather on the procedure and the process. I'd like to abstain for that reason.
Okay, one abstention, please.
Okay, two big items of note, and there'll be more said on the first one a little bit later in the meeting. EPCRs. If there's anybody in the room that's not aware, EPCRs is going, or correction, EMS charts is going away after the first of the year. Our region, Hudson Mohawk region, and Dean Romano leading the charge now is trying to be proactive. We've created a committee to review various other electronic platforms out there, something that could be of benefit to our region as a whole, perhaps. We're exploring various funding or revenue streams to perhaps at least provide seed money for an initiative such as that. I know Dean may speak to this a little later, but the committee has reviewed probably 8 or 10 different electronic platforms now, with perhaps another 1 or 2 to be reviewed. We're keeping the whole region abreast as best we can relative to developments that come out of this office. And stay tuned for further announcements. We're not sure where we're heading yet, but you know, if we could make this a regional, truly collaborative regional process, you know, that would be our goal. But like I said, stay tuned for additional. The only other big announcement on here really is the 2004 Remo banquet was finally confirmed. Tuesday, October 14th, 5:30. It will be at the Krause Center, directly across the street from Samaritan Hospital. And that concludes my report, unless anybody has any questions for me.
Anybody have any questions for Tim? Okay, moving on. Treasurer's report.
Sure. Quickly, balance sheet you can read for yourself. It is still very, very strong. Our cash position is very strong, $631,000 in assets. Our liabilities are nil, $18,000. The majority of which is instructors payable, which should be going out soon if they haven't already. I think I signed off on those last week. And the CON deposit that we just voted on tonight, the applicant is getting a refund of the majority of that check. There is one new bill for approval that did not get on in time to make the printing, and that is a 1-year subscription to go-to for $936 to allow members of REMAC and such that cannot attend meetings to join in by this technology. It's a 1-year subscription, allows us up to, Tim, 20 users?
25 users.
25, I'm sorry,
Yeah.
25 users. And it seems like a very worthwhile investment.
Okay. Anybody have any questions?
That
Comments?
comes to you as a seconded motion from the executive board for your approval, that this recall require vote.
Any questions from anyone? Okay, all those in favor? Opposed? Abstained? Financial Committee?
The only thing from the Finance Committee is that we've invited our investment counselor to come in at our future next meeting, probably will be in the fall, to review the portfolio performance of our investments. Given the where the market is, we were surprised a little bit at our 2013 performance, and just want to sit down with him and go over where we're investing, what opportunities there might be to maximize the return on the funds that we are investing.
Thank you, sir. Medical Director?
You know, so often I have these long votes. Actually, what I'm gonna do is just comment on what I just said from Mary. We've had a change in the collaborative protocol process. Reviewed the changes that we wanna make, and the updates that we need, as well as the information coming out of the AHA so far. The AHA will have their big meeting next February, and I think February or March. We'll issue their copy of circulation at some point in spring or summer. And in talking to people from all of the other regions, our goal will be to issue the large update to the protocols once that occurs. In the meantime, what we will be bringing forth and distributing for discussion will be an update to the protocols to include the category of advanced provider and removal of the intermediate provider. That will be essentially done along the model that has already been exhibited in the Western region and in Central New York. Just incorporating the changes based on what they've done already. So that will be able to actually, the problem we had in terms of meeting the 1/1/15 deadline that we had set for ourselves was the fact that the next CMAC meeting is September, the next one after that isn't going to be until well within 15, and it just wasn't possible to hit that date. So we decided to set some more reasonable goals. In discussing it across the listserv and with each of the medical directors personally, I think this is going to be the best way for us to go.
Okay. Does that cover all three of your reports?
Sure.
Okay. State EMS Council, Steve's not here, obviously. Steve Crow, would you mind speaking to that?
Yep, the State EMS Council met in May, we'll meet again in September. There were discussions of a number of things. First, TAG was appointed that will look at CLN reform, given that some of the regional councils are having challenges in completing their requirements on CLN. It's an extremely complicated process, so they're gonna look at some reforms that will help some of the councils to be more successful and being able to meet their requirements. So the TAG will look at the CLN rules and go forward from there. Article 30 reform is still out there. The Bureau of EMS has been asked by the executive branch of state government to submit or to help them develop some proposals. The likelihood that the Article 30 reforms will come back next year is pretty likely. That will, among other things, involve questions about the number of regional EMS councils that there'll be. Likely that there will be some movement towards having fewer, as some of them are having significant difficulty in accomplishing their goals. And so the first time Article 30 reform was tried, there was a very rigid number of councils that would have drastically merged from current number down to a very few. I think there's more flexibility in that right now, but I think we should expect that it will be live next year. And questions, for example, about us collaborating with some of the councils around us would be there. A couple pieces of major legislation have passed. CPR in schools passed, is now in the hands of the governor to sign. I think it'll get signed. I think the governor signed today the heroin package of heroin bills that were negotiated at the end of the session. There was some discussion about therapeutic hypothermia, and I think, Mike, you mentioned it here at the last meeting that you were at, and it's basically coming off the table in the pre-hospital environment, not because it's been proven to be ineffective, but the research on whether it is effective has now been questioned, so that's coming out. Mike talked about the collaborative protocol. A number of other regions across upstate now are working on the collaborative protocol. It looks like pretty much the collaborative protocol is going to cover everybody from here to Buffalo, from West District to Buffalo, is that right?
Yonkers to Buffalo. all the
Yonkers
way
to
up
Buffalo.
All the way up together.
So there were a couple larger blocks of groups in upstate that were doing their own protocols, and they're all coming on board, so it will be, everybody but New York City and Long Island. And it started here, so that's a pretty good accomplishment. And the last thing is that the community paramedicine tag, which I'm the chair of, will be reporting out in September for asking the state EMS Council to approve a policy on community paramedicine that can be transferred into legislation for the congressional legislative session that begins on January 2015, so that all of us that have ideas in community paramedicine will be able to effectively implement. Right now, there's a statutory bar on having that.
Okay,
And
that's it. Thank you, sir. Rich, is there anything you wanted to add?
No, that's fine.
Okay. Nurses Committee, no meeting? Oh, you did? Excellent.
We met on May 22nd. Tim talked about giving an update on the intranasal Narcan, stating that Remo was completing their stock, that the agencies would have to buy their own.
Anne Marie, can you just speak up just a little bit?
I have a report too that I can give you.
Okay.
If you want. Tim had talked about the intranasal Narcan, and he said that they, Remo was depleting their stock, and that the agencies would have to purchase their own once it was done. He also talked about the protocols, which is what really, Tim had given a report, which is what Dr. Daly just said, so I won't repeat any of that. Bigger discussion was about the restocking list again, some of the nurses having difficulty with the drugs, and some of the agencies asking for drugs that are not on the list. So they were having a lot of issues, and Tim was gonna send out another, did you do that, Tim?
Not yet.
Memo, okay. So he's gonna send out a memo reminding them. And Ellison on the med reported about the linen issue again, that they're still, they are bundling their linen, but said that they're still having an issue with that, so they're monitoring that closely. And they haven't made any meetings at we haven't had that issue. I sent out an email, and consensus was to cancel the July meeting due to the summer, so our next meeting will be in September.
Okay, thank you. MCI Committee.
No report at this time.
Membership, Lynn is not here, but I don't believe there's any issues at the moment. Nominating Committee is not effective right now. QI Committee?
We did not have a QI meeting this past month. However, we're still working on the last study that we did, the respiratory study, comparing the treatment of COPD and CHF. Or more specifically, treating CHF like COPD and the problem we're having with that. We did find some opportunities for improvement. We created an education component and sent out some communications to the physicians. That's an ongoing thing. Actually, the actual communication to the physicians will go out at the end of this month, which will be next week, and hoping to repeat that exact same study 1 year from now.
Okay, thank you, sir. We'll do county reports now. Albany County?
For those of you who may know, Captain John Layton from the Albany County Sheriff's Department, the Director of Emergency Management, is moving on at the end of the month. He's going to Homeland Security, be Deputy Director of Homeland Security. In the meantime, I'm not aware of who his replacement might be, so stay tuned.
Tom's stepping up for now,
Tom Remsco.
but that's only temporary.
Thank you, sir. Columbia County?
Columbia County is interviewing for a replacement for a medical director. We interviewed a candidate last week and hope to have one on board within the near future to replace Dr. Chapin, who is our current medical director, who only visits occasionally now.
All right. Greene County?
Good evening, all. Our countywide ambulance task force committee has met with our consultant. We're expecting the first of 3 analysis reports next month. And the town of Catskill Town Board has voted unanimously to put on paramedics on their ambulance. So that's it for now.
Rensselaer County?
Country Fest is returning this year. It'll be next month, the 13th, I believe, of July. Our CFR class that Lynn is teaching is underway. going strong. That's about it.
Okay, thank you. Saratoga County, no report. Schenectady County?
No report.
Moving on to new business, we have core sponsorship renewals for both Remo and Hudson Valley. Anybody have any questions about those? Okay, a motion to renew those? Anyone? Thank you, Jim. Second? By Rich. All those in favor?
Aye.
Opposed? Abstain. We already covered the first two items, so we'll move right to our guest, Mr. Taylor. How are you this evening, sir?
Good, yourself?
Not too bad. Floor is yours.
Thanks for having me. For those that have not met, my name is Michael Taylor. I'm from the Bureau of EMS. I'm one of Mary's counterparts, so if she pokes me, it's all in good fun, because I poke her every day in the office. We're going to Nassau County here at the end of this week, and we'll let you know how that goes. If we both come back, it was a good time. If one comes back, you know something happened. I've been with the Bureau for 10 years now, done various things. My current assignment is the transitioning of the entire state from paper to electronic PCRs. We started this whole thing at the Bureau level. We've had electronic PCRs various places in the state for well over 15 years now. But at the Bureau level, we started this back in 2008, so this will be 6 years into it here. We started with a grant to create the Image Trend State Bridge, and from there it just took off like wildfire. Got out of our hands at some times, and we've had to wrangle it back in. But the one thing that we've never had an opportunity to do is to come and sit with the Remscos and the Remax, so you can hear it straight from the horse's mouth, if you will, ask questions directly of the state, and kind of get a feel for where we're going. We've never had the ability to come out and actually meet with the regional council folks. It's always been through hearsay, through the hearsay per se, from the regional directors, and you know what I mean, from the regional program agency directors and from the state council, passing information down and such. But I just think that it's come time that with everything going on, that the regional councils have a chance to see me face to face and ask questions and kind of see where we're going. To date, we have 3.5 million records in our state EPCR bridge. I estimate that we are on track to put 900,000 to 1 million records in our state bridge by the end of 2014. In contrast to the paper PCRs that we did for 40 years, we put about 2.5 to 3 million records in paper is what we always did. So we made great progress in getting people converted over, getting the services converted over to electronic platform, being about 1/3 of the way there, if you will. Total services, depends on how you look at it. We have over 1,800 agency codes out there, which includes BLS first response, ALS first response, and anything that transports gets an agency code. If you want to count just the certified services, which is the ambulances and ALS first response, then you're looking at about 1,200, a little over 1,200 services statewide. I just counted here tonight, we have 470 services statewide that are electronic PCR at this point. And that runs the full gamut across the state. We have large ambulance services, small ambulance services that I thought would never be electronic, that I was shocked when they actually were and had been for at least 5 years. BLS first response services that want to do electronic. Why? Don't know, but okay, come on board. On the reverse of that, we have large and small services that have not gone electronic, mostly because of financial reasons. It is expensive startup for a small service with limited assets, and it is very expensive for large services with a lot of people to train and a lot of vehicles to equip and a lot of servers to put in and software to install. So doesn't matter which end of the gamut you're on. We have services that are on electronic and services that are not on electronic, for the same reasons at either end of the gamut. The issues that we are dealing with today are things such as data quality issues. Just because we are collecting data electronically doesn't mean that it's being collected correctly. The part of that is the getting used to electronic submission, having to actually type into a computer rather than hand scratching a piece of paper. Again, that we did for 40 years. But the data quality is getting better. A year ago, we had lousy data quality because people didn't know how to interpret the data quality validations that are out there in the computers. They didn't know how to run the reports that they should have. I spent the last year teaching folks how to do that. Once they've learned how to do that, our data quality statewide has gotten better. Now we're to the point of the computer says that our data quality is good, but the way the computer is programmed is if there are questions that allow you to put in a blank for an answer. Now I'm at the point of figuring out how many blanks are in there. And that'll be a task for one of the researchers in the Department of Health to actually look at the background, the whole data table, and tell me where the blanks are. What that means is that they're not submitting the data. Although the computer thinks they are, in reality they're not, and we'll have to address that missing data piece is what will be the next in the data quality. But our data quality is improving. We're finally getting to the point where we would have some confidence in actually running reports out of the system. Garbage in, garbage out. If you don't understand to make sure that your data in the background is quality, you're not going to get quality reports or accurate reporting. So that's where we are with data quality. Other issues, you heard that EMS charts is going away. Statewide, as I said, we have 470 services electronic. 255 of them are EMS charts. And another 50 of them, 50 services statewide, we're probably looking at EMS charts when EMS charts decided that, well, I shouldn't say decided, they lost the lawsuit and things rolled from there, okay? They got the injunction against them. Now it's questionable as to how long they're going to be around for and such. So the EMS charts vendor being gone is a huge issue that we're dealing with statewide. I have to tell you that every region is pretty much dealing with it the same way. They are attacking it from a regionalized perspective. Now is the time to look to see what can we do to build regionalized EPCR systems, or at least have the support from the region to find one vendor or two vendors that everybody would be happy with. That's how EMS charts became so popular in the state, is folks like them. Regions went out and got grants to get services on EMS charts, and they RE/MAX said, yes, EMS charts is one of the vendors that you can use, and went through all of that support and such to get EMS charts. We never expected that EMS charts was actually going to possibly close its doors. So now the regions are all back to, okay, where do we go from there? And nobody is sitting on their hunches. They're picking up the pieces and saying, let's move forward and let's figure this out. How could we do this better? Let's take this as an opportunity. Other issues that we are dealing with, the EPCR is going into the hospitals. That continues to be an issue. For 40 years, the hospitals expect to get the pink copy of the paper. Now they don't get the pink copy, and it seems to be disturbing to them. They don't know what to do with our electronic data in a lot of cases. Some systems and some hospitals have worked that out. Most in the state have not, and they're still fuddling through printing, faxing, scratching on cheat sheets and handing those in, whatever they need to do. We are working on a solution that would address that statewide, at least as a fundamental base of this is how your electronic PCRs can electronically get into the hospital. And if the regions decide, or hospitals decide, or systems decide that they want to go above and beyond that, that's fine. But we're working on a baseline model for the electronic PCRs to get into the hospitals and in a manner that the hospitals can and will receive them. Outcome data, so I just spoke about our data going into the hospital. We also need, for the first time, their data to come back to us. For medical directors to be able to see what happened to the patient, for QI committees to see what happened to the patient, for just the provider to see what happened to the patient. Did they get the diagnosis right? Even though we technically don't diagnose, but did they diagnose right? Was the treatment we provided in the back of the ambulance appropriate for that patient? Things such as that. Outcome data is also important as we move into trauma centers that are accredited by the American College of Surgeons. They want outcome data sent back to EMS providers as part of the trauma system. We need to facilitate that. So we are looking at ways to get that outcome data back into our EPCR system so that it's not a one-way street, it becomes a two-way street now for the first time. A lot of that data going in and data coming out will be facilitated, I think, through the regional health information organizations and the NICE and the SHINY and the electronic health collaboratives that the Department of Health and others have built over the last few years here. There is a regional health information organization here. I don't know if it's out of Albany or I think it's out of Latham is where they're based out of. Their job is to link all the health information, all the healthcare records together for this region. There are 10 of those across the state. And we're going to be working with those to see what they can do to help us get our data in and get what data we need back. That should prove to be very interesting and very well received once we start shuffling data back and forth. That's going to link EMS into the rest of the healthcare stuff, just like it does the doctor's offices, the CAT scans, the labs, clinics, and all of that. We need to be part of that, so we're pursuing that. One of the biggest things that's coming down the road is this transition to NEMSIS version 3. Right now, we are on NEMSIS version 2, have been for the last 10 years, or NEMSIS version 2 has been out there, so we've been on it for the last 6 years. We've been doing EPCR. NEMSIS version 3 is being created as kind of the be-all, end-all for the EMS product. It will be health level 7 compliant. HL7 is the gold standard, I guess, for how all of the healthcare electronic records will talk to one another. NEMSIS version 3 will meet this HL7 standard so that EMS and all of our EPCR vendors will be able to talk to the rest of the healthcare world the way that the healthcare world wants to be talked to electronically. The downfall of that is where our providers just got used to the system they have, now they'll have to get converted over and get used to a new system. Depending on what software vendor, that new system could be very different, or it could be they see a couple of questions go away and they got a couple new questions that show up one night. Depends on the software vendor. So as far as the way we're going to transition New York State, it will be truly vendor by vendor. ImageTrend being the state's vendor, we will get ImageTrend over onto NEMSIS version 3 first, make sure that ImageTrend can talk to ImageTrend, and there's no problems there. And then we'll move on to, well, we were going to move on to EMS charts, but we'll move on to whatever there is, whether it be ESO or Zoll or IPCR from Forte Holdings or whatever else is out there to go next. But we'll transition vendor by vendor, and over the course of, I imagine, 2, probably 3 years before we get the entire state converted over to NEMSIS version 3. And that's okay. That's okay, because it's a better standard, and it's worth taking the extra time to make sure it's going to work right, rather than just snap our fingers and say January 1st you will be, because that just will never work. And we don't want to crash our entire system and tip over our providers any more than what we did by simply going to electronic PCRs. That has been a tip over for some people. So that's where we are today, and those are the issues that I am dealing with today, not just here in Remo, but all 18 regions across the state. One thing that I want to stress is that we are in this together. This is not a Remo thing. This is not a Hudson Valley thing. This is not a Mountain Lakes thing, it's not an Arabs thing, it's not a New York State thing. It's a whole thing for the New York State EMS system, which we are all one big, happy, dysfunctional family in. We're in this together, so nobody should feel left out alone or afraid to ask questions or anything like that. There's a lot of support out there for electronic PCR, and anybody that's struggling or having trouble, they just need to ask the question, we need to talk it through, and we'll get through this together. We will, in the end, be a better system. It took us 5 years to wrap our own head around what electronic PCRs mean for our New York State system. It'll take us another 5 years probably to make it right for New York State, but we will make it right. So, with that being said, I am here to answer any questions or discuss anything you want, as long as the chair wants us to discuss it. And if the discussion goes long and the chair wants to cut it off, I'm here till the end of the meeting. We can talk afterwards too. It's up to you how you wanna go from here.
Well,
But I do thank you for letting me sit here and your time and such.
Yes, we'll start off with questions. Whoever has any questions. Dean, do you have any questions at this point?
I do not. We have an ongoing conversation about this on a regular.
Does anybody else have any questions? All right. Thank you for coming.
Thank you for having me.
I do have some comments though, on the back of what Mike was talking about, where we're at regionally. Because we know that EMS charts is going to come to an end sometime in January, we are starting to look at the different vendors that are available and find out which vendors will do what we need done on a regional level for the data collection. And taking into account some of the challenges and difficulties we had collecting data in the past, and what works well, what does not work, and looking at the different vendors and what they can provide. The other thing is, we have agencies that do 300 calls, and we have agencies that do, 100,000 calls, or close to, many calls. And those agencies, we're trying to get a good price for everybody. We're trying to get everybody to benefit from the greater call volume. In Remo, our region, we have about 210,000 charts a year, and of that, it's 160,000 of them are electronic. And of that, 85,000 of them are on EMS charts. So we're looking at collectively going, purchasing a vendor to service 85,000 charts potentially. And that represents 40% of our chart here in the region. So it's a significant footprint, and it's a significant challenge that we need to make sure goes smoothly for the larger and the smaller agencies. And so we're working on that. We have a group of people who've come up with a strategic plan on how we need to pull those things together and creating a committee to truly address this in a formal way. So to this point, we're vetting out, we have 7 vendors that we've looked at. Some of these vendors just can't meet the need, the regional need. Some of them have come right out and said, we don't have a product that would work for you. And that's, that's good to hear. The other thing is, we are hearing from the state, and I've been on one state conference call where I'm hearing the challenges that other regions have with these vendors, and so we know where to dig for the problems and what places to stay away from because of the problems that exist other places. So it's been actually a very educational process, but it's also been a process that I think that's really ultimately going to benefit the region for the data that we can get back for medical research and best practice and standardizing the way we chart.
I think Dean highlights it pretty well. When this the whole idea of EMS charts disappearing first crossed my desk, it really was something that was worrisome, and Dean called almost immediately. I could see his finger on the pulse of what was going on here, which was really good. And we spent a lot of time talking. we have a lot of different constituencies that we need to make sure are heard and heard well as part of this process to find a single platform if we can. We need to recognize the fact that because the regulations put in place by the Bureau when they initially started approving EPCR programs, we will continue to have charts in the region that will not enter into any regional database that we collect unless we get those secondarily dropped into another bridge, which still means we won't be looking at the chart, we'll be looking at information from the charts. We'll be better off if we look at the primary data or as close to the primary data as we can, because it'll be realer, if there's such a term as realer. And it will be more effective. We will all be more effective, each of our providers, when they go to their other job, and let's face it, they've all got other jobs, all right, are doing the same type of documentation on the same software, hopefully using the same type of hardware. It'll just make things easier. And from a hospital perspective, the ability, as Mike says, for there to be a single build out of an HL7 data set into any of these back-end programs these hospitals have will make it much easier. If you look just at the big three in terms of hospitals that we have regionally, the Ellis system, the St. Peter's Healthcare System, and Albany Med, that's hundreds of thousands of encounters, but they all use the exact same Siemens back-end product, something called Sorian. That's all I can say about that system, but not talking about that system, all right, it would be good to only need, to need less build-out for that hospital integration, because that's one of the places the real success is going to be. Dr. Bosco is working with me on a letter that will go to the hospitals asking them to help us with this transition and to make the most of this opportunity. I see this as a huge opportunity. As we work on our protocols now and we try to figure out what do we need for what do we need for pain management training? How many of our patients get pain management? That we can start to tease out because of controlled substance records. After that, what do we need for agents to control rapid AFib? Couldn't tell you. What do we need for dopamine? How many times did we use dopamine last year? Nobody knows. We need to know these things, because we need to know how often we should be retraining our providers. We need to know how often we should be reviewing the medications that we're carrying. We need to know whether or not there's any specific patient sets that we should be working on harder than others. It's really all important things at making this system as robust as possible. It's the next step to taking Remo really into being that incredibly high-functioning system that we're building slowly. And we've got the providers to handle it. So the question is just seeing if we can get them there. And this will be huge. Of course, then you get into the nickels and dimes of this thing. And if we can use 85,000 charts as a way to negotiate pricing, that'll make a huge difference for any of the municipalities, as well as all of the smaller agencies along the way too. But we need to make sure that this can work. So, thank you all for working. I don't have a horse in the race. Don't care what the product is in the end. I just know that I want to be able to look in one place for all the information, and be able to get the answers to bring to the table. So, good luck.
Just a general question. Is there a current region, similar to Remo, that is sole electronic?
Yep. Susquehanna, the Binghamton region, they've been electronic for years. They, back, I think in the late 90s, the Bureau gave them seed money to start the first regional electronic PCR system, and it was a homegrown system. They, I think 3 years ago now, they did a cost analysis and realized that the expense of maintaining their own system had gotten to the point that it was going to bankrupt them. So they went looking for a commercial vendor. They brought together stakeholders from across the region, from all different types of services. They looked at many different products. They settled on the Image Trend product for their regional bridge. So yes, they have Image Trend as their regional bridge, and it's, they have all but, I think, 3 of their services using that bridge, typing directly into that bridge as their EPCR system. The other 3 services chose to, for whatever reasons, not to use Image Trend. It wasn't conducive to their doing business with the billing and this and that. But what happens is those softwares dump into the regional Image Trend bridge. And then as far as the state data goes, that bridge is what takes all the data from Susquehanna and pushes it up to the state Image Trend bridge. So yes, Susquehanna is truly a regional EPCR system. Now, the step kind of below that is not a regionalized system, but a system where everybody agreed to use the same vendor. We have several of those. Monroe Livingston Monroe Livingston and Finger Lakes and most of central New York agreed to go with the EMS Charts product. The commercial services out there stuck with the Zoll product because of in-house servers and such, but it connected into their own CAD and their own billing software that they had from Zoll for years. So the commercial services stuck with their Zoll product, while the rest of the regions said, yep, EMS Charts looks good, it's a good idea that we all be on the same thing, so they just, gentleman's handshake, they all came out on the same system. So, but it was, EMS Charts sold it to each individual service, not as one region. But still, through that, they were able to do group pricing and such to get the better rates. So there's a couple of good regionalized models out there already that have been in place for a long time.
Dean, what's your goal as far as time frame to interview the rest of the vendors and get together to kind of come up with a recommendation?
Well, the dates are not hard and fast yet. However, we're hoping by the end of, by mid-July, to really have a short list of vendors to present to a committee to be able to look at. These are the ones that will do what we need, and what are the pros and cons of that. Obviously, we want to roll this out before EMS Charts goes away. We're suspecting that to be mid to late January. Ideally, to have a rollout in November, because December is almost impossible to do it. It would be great to do it in November. I don't think there's enough time, though. I think that we're really looking at a December rollout. And I think January 1st is too late, knowing it's going to be gone by January 20th or so. You ready?
So you talked about seed money to Susquehanna.
That was,
Got any cash for
that
us?
that was 15 years ago.
Thought I'd ask, Mike. Can't blame him for trying.
Any other questions for Mike or Dean?
No, I'm gonna bring it up just because Mike, I keep getting the phone calls and I have to try to figure out how to transfer them over to his desk with their new system. Several agencies have called up asking, well, I have this system, or my advisory board says I have to go with this system. And the official answer for whether they have to go with one remote, or I'm just picking on remote. But the people have asked, if my remote, or if my region says I have to use, Charts XYZ, do I have to do it? Mike, you know?
It truly is up to the service what EPCR vendor they want to use. Because by law, it is the service and their providers that are responsible for providing the document, for keeping the documentation, and the data belongs to the service. So it really is up to the service what vendor they want to go with. And as I said, they have different reasons for choosing their vendors. The commercial services tend to choose Zoll because they already have Zoll products. Others choose choose EMS Charts because of other things, but it really is up to the service. But to this point, we've never had that question really be questioned. It was always, as I said, a gentleman's handshake, an understanding that it was for the good of the region, and folks just came on board, or if they did not want to use the same software, cooperated so that the region got all the data and got what the region needed to do CQI and what the medical directors needed to provide proper oversight.
Any other questions, anybody? All right, don't have any other business that I'm aware of, so motion to adjourn?
If I may,
Yeah.
couple of quick things as comments were going on, I just wanted to talk them out there for everybody. A quick redirect, my apologies. As Steve mentioned, I believe today 6477 was signed. This will allow delegated prescribing for naloxone, which will make all the difference in the world in terms of the law enforcement projects we've got going on out there. Will make an incredible difference in terms of how the drug is out there as well. Currently, the strength of our BLS program that we had is we could put out naloxone just like you could an AED. With the law enforcement products programs, we've had to issue naloxone to every single cop in any agency. That's kind of a tough operational lift. It's eaten up a lot of the Attorney General's money, which I guess he stole from a drug dealer anyway, so it doesn't matter. But at the end of the day, it was a lot of money that could have been used for something else. So in terms of where this is, Colony was the first local police department to be completely trained in naloxone use, but we didn't put it out because we didn't want to put out 110 doses of naloxone on the street. We will be putting 10 into the 10 defibrillators we have in the street as backup for the EMS agency once we have the go-ahead and the emergency regs are in place. Guilderland, they were going to put 35 doses of naloxone out there in the street. They'll be able to put out just 5. So it's going to be a huge difference in terms of the oversight that's going to be needed. So that'll be huge. So great that that got signed today. The other thing that was important that came out of the CMAC meeting is we have a new definition of hypoglycemia in the state. We'll be issuing an advisory to this effect. Hypoglycemia is effectively defined as having a blood glucose of less than 60. All right. That came as a request from the EMSC group in order to make it as seamless as possible between children and adults who, after all, are just big children. We made it 60 right the way across the state. The advisory that we'll be issuing will basically say, ask providers to be wary of adult diabetics and understand that an adult diabetic with a blood glucose of between 60 and 100 may still be hypoglycemic because they're used to having a high blood sugar. So if you believe that there is somebody who is acting hypoglycemic and has a blood sugar of 62, titrate in 5 grams of dextrose. Give them 50 milliliters of D10, see if they respond. If they don't respond, they are not hypoglycemic, go ahead with care and continue. All right. It's a little bit of a clarification to make things easier. The advisory and then subsequently the protocol will reflect that to make sure it's as easy to understand as possible. That's it.
You sure?
Cut me off now before I keep on talking. Also, as we are right now.
I make a motion that Dr. Daly is sure.
Ken, as we are right now, this is about an hour longer than most of your meetings. So
Apparently I've lost my touch. We're not meeting this seat. Motion to adjourn.
Do we have to officially suspend for the summer?
We can. Would you like to make that motion?
Sure. Barring any action that requires the organization to meet, I would move that we suspend meetings in July and August and reconvene in September.
Second to the motion? All those in favor? Opposed? Abstentions? So carries. Yes, sir.
Should we have another motion to follow that that suggests that if necessary, we'll conduct any business needs to be conducted by email?
Friendly amendment? Sure. I'll do that.
Well, the motion
Yeah, you
already
did.
carried, so.
Oh.
Yeah, I forgot.
But just make another motion.
Make a motion that any business needs to be conducted that is not statutorily required to have a in-person vote be done by email.
Seconded by Mr. Vina. All those in favor? Opposed? Abstention. Okay.
Now you got a motion to adjourn. I'll make it.
All right.
Motion to adjourn.
Well, everyone's leaving.
All right.